Good evening, everyone. It's my pleasure to welcome you all to this evening's Society for Endocrinology and YDEF National Taster Day. My name is Becky Sagar. I'm a specialist registrar in Leeds, currently out of programme doing a PhD, and I'm also one of the committee members of YDEF. For those of you who don't know, YDEF is the Young Diabetologists and Endocrinologists Forum, and it's our national trainee society, which is trainee-led and runs a variety of education opportunities throughout the year. Hopefully of interest to this audience, we are looking to recruit a junior rep for the committee soon. So look out for that, and you can find information on our website if you just Google YDEF or our Twitter. As I said, it's my pleasure to host this evening, and we've got three fantastic speakers covering a few different topics, focusing on endocrinology tonight before tomorrow's webinar, which will have three other speakers focusing on diabetes. From a Q&A point of view, I'd encourage you all to, during the talks, submit your questions via the chat box. And after the three talks, we will have roughly 15 to 20 minutes, I think, of Q&A where we can cover all of those questions. So without further ado, I'd like to introduce our first speaker, Jolyon Dales, who is a final year specialist registrar in Leicester. And today he's going to be talking to you about his insights into making the decision to specialise in endocrinology. So as I said, he's a final year registrar in Leicester, having completed both his core medical training and a clinical fellowship in Leicester. Currently working with an interest in medical management, and is also on the Society for Endocrinology's Early Careers Committee and also the peer review working group. Jolyon has also taken some shared parental leave during his registrar years and is working less than full time. And I'll hand it over to you, Jolyon.
Thank you very much, Becky. So I'm Jolyon, so I'm a final year registrar in Leicester. And today I'm going to talk a bit about my career journey, the application interview process and changes that have occurred with it. Also what I do in a typical week. And finally, what I wish I'd known 10 years ago. And I am a member of the Society for Endocrinology Early Career Steering Group, in addition to other committees, but what I expressed tonight are my own opinions. So going back, why endocrinology in my career journey? Now, I've been a doctor for just over 10 years now, and I did undergraduate integrated degree, and then have actually spent all of my working life in either Kettering or Leicester. And I think for most people, it's like a funnel. So you start off at medical school knowing what you definitely don't want to do, and over the years went on during foundation year, I knew I wanted to do medicine, and as I got into core medical training, my interest in diabetes and endocrinology really peaked, and I decided that was the specialty for me. So I'm due to become a consultant in spring next year, and I'll actually be acting up as a consultant for mid-December. And this is when you're essentially on the consultant rota, but you still have a named consultant supervisor. So I'm going to talk a bit about my career journey. I think things have changed in terms of the application process and the time in medical training, but also I'm sure things will change as well in the future. So this is the current career training pathway for non-academic diabetes endocrine trainees, and I won't spend too much long looking at this, but I would encourage you to go on the JRC PTB website to make sure you're familiar with it. And the main thing here is there's two levels of selection. There's a selection for internal medical training, but also selection at IMT3 to enter as an ST4 trainee. I won't dwell too much on this, but just be aware if you're interested in academic training, there's the academic training pathway. Now, this can differ from different areas, and I know in some areas that actually the academic training pathway doesn't actually add time, but within Leicester, IMT1, IMT2 takes 3 years, because essentially you have an extra year as part of an academic clinical fellow, and then your extra time as a registrar can vary what you do during that time. So obviously we've got a range of people at career stages on the webinar, and I think I would say when choosing your foundation year jobs, match your jobs to interest you. But what I'll go on to say is what you do as an FY1, FY2 is very different to being a registrar consultant. And if you particularly want an academic job, which is now the specialised foundation programme, you may have, and you don't have necessarily as much points as others, you may have to think about which location you want to apply to, particularly as you can see from here, and this is data from 2020, Northwest London has far higher competitiveness compared to other areas of the country. So I'm going to briefly mention this. I would encourage you all to look at the IMT recruitment website and also the ST4 recruitment website. Now, the main change that's happened since I certainly applied for IMT and for ST3 was that you don't get any points anymore for having a BSc or any undergraduate degree, including an intercalated degree. This was a decision made as access to an undergraduate degree isn't the same across medical schools and isn't the same for international graduates. So do be aware of what the points are and what you might get for it. So for example, you get 4 points for a PhD or an MD and 3 points for an MSc. You might get additional points for a distinction for medical school. And actually you get 7 points for an oral presentation at a national conference, and it goes down depending on whether it's been a local conference or regional. You also get obviously points for publications if you're first author on a PubMed site of publication, in addition to teaching, so organising a teaching programme. So do look at this and do work out where you may want to improve your CV and your application. So the IMT interview consists of a clinical scenario and a patient handover scenario, and this isn't anything that's particularly complex or you won't have encountered during your foundation year 1 or foundation year 2 time. It may be around ethical, and it may be around diabetes or endocrinology, or it could be any specialty. There'll also be an ethical question where you're not necessarily meant to give the right answer, but you might be asked to talk through the different ethical dilemmas and the framework in which you might answer it. Also suitability and commitment to IMT, and also one where it goes through your application and your training up to that point. Now, what I'll point out here is this is for ST4 rather than IMT, that you have a similar scenario with a clinical scenario and a diabetes and endocrinology, and also your suitability as a medical registrar. Now, the combined score is a combination of your interview and application score. So actually, if you have a strong application, you can already have a good head start when you go into the ST4 interview. Now, one of the things in applying for ST4 is that this is the competition ratios. You can see actually there was a significant increase in competitiveness in 2022 last year due to a year of not recruiting because of the change to IMT length of training and also the effect of COVID. Now, one of the things about when you apply for registrar training is that actually each area will declare how many posts they have, but these posts are dependent upon other trainees finishing and becoming a consultant. So for example, if someone chooses to spend 2 years doing an MD, that will therefore mean that their training number isn't released for 2 years. Therefore it mean that if they would say that they had been due to finish in a certain year and their training number would be released, it may not be that there's actually any numbers that year. So actually the numbers released can be quite low compared to say for IMT or foundation year 1 or 2 recruitment. So I think my overall reflections on it, particularly the changes to it, is actually the places are low. And so it might depend on who else is applying. So when I applied, there was only 1 job in East Midlands South. So therefore, if you're up against a very strong candidate, you may have a more difficulty compared to some years when there may be 3 or 4. Now, one of the things I would admit to 5 years on is I really did muck up my interview quite badly. But thankfully, because I went into it with such a strong application, it meant I still got the position and the training post that I wanted. And do keep, obviously depending on what stage you're at, do keep up to date with any changes, because it may be for those in foundation year 1 and foundation year 2 that actually how the application is scored and the interview may change in the few years between now and when you might potentially apply for diabetes endocrinology. This is my personal opinions. I recognise why undergraduate degree score has been removed, but I think the same can be said for everything else in the application form. If you have a very heavy job with no time to do audit or research, you're going to struggle to get more points on the application. At the same time, funding for postgraduate degrees, for example, teaching degrees, can be several thousand. So again, there may be different access for being able to do this. But what I would say is easy points to do poster and oral presentations and delivering teaching sessions. Ideally, you do things because you want to, but I think this is a way you can potentially boost your application and also get more of an insight into the specialty itself. And I'm 34, I did my last exam age 31, which is a specialty certificate exam. So exams don't finish when you finish medical school and will carry on right up until maybe a couple of years before you become a consultant. Now, in preparing for this, I did speak to some international medical graduates because I can offer my UK trained and UK medical school experience, but for international medical graduates, it may be a challenge not knowing the system, and particularly the previous experience with audits, quality improvement projects, publications, and signing of competencies may not be the same. So I think what I would encourage you is to get in touch with international medical graduates who you already know within your specialty or within the hospital where you work, who are in higher specialist training. Find out what they did in order to get their competencies signed up, and also find out particularly what they did in order to boost their CV, so that you can have as good a chance as anyone else in applying for specialty training. So I would say life as a clinical registrar is much better than FY1, FY2 and IMT. You get a huge amount of variety, and there's more opportunity to pursue time for audits, research and teaching. And this is even outside of formal research pathways. So in my typical week, I might do 1 or 2 days in the ward, but I'll also have 3 or 4 diabetes clinics and a couple of endocrine clinics, in addition to protected admin time. Now, I say I'm nearly a consultant, and I've got just over 5 years of training to talk about. In that time, I've seen 3,346 patients in outpatients clinic, which roughly 2/3 have been diabetes. And you can see the effect of COVID here, because I've seen 400 people in virtual clinic. And with endocrine, again, it's a roughly 50-50 mix between in-person and virtual. But you can see the breadth and the amount of what I've seen in specialist training clinic is huge, and certainly not anything like what you might get to sample as a SHO or foundation year. And here's my cumulative number of patients over 5 years. And you can see that to start off with ST3, ST4, you maybe have more time on the ward, so it may not be that many patients. And obviously you may have things like the COVID pandemic or getting COVID yourself that might affect it. But overall, the experience of what you can see is huge. And this varies from trust to trust where you might work. I've seen over nearly 1,000 patients in general diabetes, in addition to a large amount of patients in foot clinic. In addition, or you've also got the other specialty clinics such as antenatal and young adult clinic. Now, endocrine, you can see, I said over 1,000 patients, a huge case mix of what you see as a registrar. Particularly the most common one you would see would be hypothyroidism, but also things that you might rarely see as a IMT3 or below, such as primary hyperparathyroidism or diabetes insipidus or prolactinomas. And you're probably quite used to referring patients with adrenal incidentalomas, but they're quite common to see in clinic as well. So my own appraisal, I'm glad I've done, gaining research experience, even though I didn't follow a formal research pathway. I'm also glad I've got 6 or 7 publications and done a large amount of presentations, and both in terms of local, regional and national level. One thing I kind of regret is that not attending more conferences early on, including during medical school, because I just didn't think that necessarily I could give it the time, when actually I kind of wish I had done. It's always a balance, particularly if you're on a academic and clinical work, in terms of balancing the things and commitments and things you start. There's a few projects that I started that unfortunately I didn't finish because of time pressures. And now I'm managed to do quite a bit with the SFE, including on being on the early career steering group, the Society for Endocrinology peer review. And I actually wish I'd done it earlier in my training, because this would have given me more chance in my training to get involved in such things. So as a final slide, I would encourage you all to look at all these websites. Obviously, some may not all be relevant for you, but particularly the 3 at the bottom, which is the Society of Endocrinology, Association of British Clinical Diabetologists, and also Diabetes UK. Many thanks.
Thanks so much for kicking off the webinar. I'm just going to remind everyone to submit their questions for Jolyon in the chat box for the Q&A session at the end. So he'll pop back again for that session. And without further ado, we'll move on to the second talk. So video is on. So Dr. Hamid Mani is our second speaker. He's a British Iranian doctor, having immigrated to the UK back in 2004, starting off in one of the first cohorts of foundation trainees in Liverpool before moving on to the academic foundation pathway. He continued as an NIHR academic clinical fellow and PhD, and his training as a specialist trainee and clinical lecturer in Leicester before starting consultant life in Kettering General Hospital in 2018. Hamid has gradually developed his clinics to meet the service needs of a district general hospital, as well as his research and academic interests in a variety of things, including PCOS, young adults with type 2 diabetes, antenatal care, monogenic diabetes, and diabetes technology, amongst other things. And he's also been the clinical lead of the service since June 2020 and has introduced a variety of interventions, which is particularly impressive given the timing with COVID. So welcome to Hamid, who is going to speak to us about pursuing an interest in endocrinology, particularly in a district general hospital. Over to you.
Hi, thank you, Becky, for having me, and Society for having me. So let me share my slides. There we go. So yes, I'm Hamid Mani. I work in Kettering General Hospital, which for anyone who doesn't know, it is center of the world at the moment. So it's a district general hospital with almost 500 beds, 560 beds. And this is our diabetes center, where my office is and where most of our specialty clinical activities happen. So Becky briefly reviewed my career pathway. I started my specialist training as an ACF following my academic foundation program in Leicester, and then I went out of program, did a PhD, and then I came back as an academic clinical lecturer, finished my SPR training after that, and it took me almost 9 years. My SPR, my specialty training, but that was a research-based training. I finished my training, CCT, Certificate of Training, in March 2018, and then started a locum consultant job in Kettering General Hospital in the April. So I had almost a month of doing Lego, and you see the outcome of that. I tidied up that room, which was a mess. But that's the only time I felt that between the training and going to start a consultant career, I could have my own time. And so I did, and I enjoyed that. And then subsequent to my temporary locum job, I had my permanent job in September 2018. So the process, I don't want to bore you with the process of applying for the consultant job, but the process is that the consultant jobs come out and you see if that's something that suits you or you would like to do, the area, the environment, the department, the hospital, the locality, where you go, do you see yourself living in that area with your family and work-life balance? Is that suitable to work there? And then ongoing life. And then what happens in the consultant life, Jolyon was referring to this, that during the SPR time, we always are protected by having a consultant around, and we always are covered by going to a consultant. When you become a consultant, you become an independent person. And while you still can go to someone, you will go to colleagues and you ask for second opinion, you will go to MDTs. But at the end of the day, the end of the line of the decision-making is the consultant. And you have all seen it in their career through the hospital day-to-day life. And consultants started working on a job plan. So the consultant jobs are offered based on a job plan. So for example, this was my first job plan, which was offered to me. And I'll go through all the details of this job plan and how I tried to change it to enjoy it more and more in the past 4 years. And each job plan has a PA. So every half of the day is called a PA of activity. So every day is 2 PA. And every PA is almost 3.5 to 4 hours, depending on the contract and how we see it. And so in each PA, we define some activity. So my first job plan when I started in September 2018 had 11.5 PA. So it was more than a whole 1 week working. So I had some time working before 9 and after 5. But that was 2 ward rounds and 1 on-call PA. So when I was on call, and my on-call pattern was as part of the hospital rota, 1 in 16 in the medical on-call, covering medical admission unit, and during the weekdays, and 1 in 10 during the weekends. And then I had half a specialty activity for diabetes clinics and half a specialty activity for endocrine clinics, and half a day of admin to deal with the blood results, do the letters, chase the letters, all those things. And 2.5 PA, which is a day and a half of almost of specialty activities, which is dealing with your emails, audit, research, governance activities, mortality, morbidity meetings, education supervisor, clinical supervisor, all those activities fall under the SPA for a consultant. And then because the Kettering Hospital wanted to keep me in Kettering after my locum job, they offered me a 1 PA of research because of my background of research and 1 PA for service development. So I had extra PAs of activity, which gave me flexibility to do extra activities. So looking at the consultant diabetes endocrinologist data, this is the audit from ABC Association of British Clinical Diabetologists, a survey in 2015-16, and that hasn't changed significantly, I don't think so. Most of the diabetes endocrine consultants do both diabetes and endo, almost 70%. 16% do only diabetes, 8.7% do only endocrine, but majority, like myself, we do both diabetes and endocrine in a district general hospital, or even if in a tertiary center, some consultants do both. So moving on, I needed to start changing my job plan to enjoy it better and then suit the service needs. So the first change that I started to add was I needed an antenatal activity. So our antenatal clinics were populated. So we added a type 1, type 2 diabetes clinic as a pre-existing pregnancy clinic. And I enjoyed teaching and interacting with medical students. So I added an hour per week of interaction with medical school and medical students to supervise them. And they would attach to me, they would come to me, discuss their cases. And I teach for the medical students for the diabetes endocrinology in the rotation to Kettering General Hospital. After a few months, this is first 9 months, this is 9 months is a good period to assess what's the outcome of your activities. And so this, I had in the first 9 months, almost 1,000 patients on my clinic lists, almost a quarter of them diabetes and half endocrine, and almost half of them did not attend their appointment. So this is before COVID. This is where we were face-to-face clinic dominantly. But you see that I used to see twice as much endocrine as diabetes patients in my clinics. And then when looking at the endocrine activity, almost half of my patients in my endocrine clinics were thyroid patients, while the rest of the endocrine cohorts of patients are almost similar. The pituitary was a bit more dominant because we see a lot of prolactin, high prolactin patients in a DGH hospital as a consultant. But half of my patients being thyroid made us think, what is that? What is it that we can do to start changing the pattern? Therefore, we made a case and we set up a virtual thyroid clinic as once per month to follow up our thyroid patients. And this increased my job plan and my activities. You see that on top, my PAs started with 11.5 PA and now it's 12.5 PA of activity. Moving on, In June 2020, at the height of COVID, I accepted to become the clinical lead of the service. There was a need at the time, and the service needed some change, and therefore we started to work on those changes. And we appointed an endocrine pharmacist, and then we shifted some of the thyroid and adrenal cases to endocrine pharmacist. The increase of a specialist diabetes nurse activity, so it allowed us to do more diabetes related activity centered around nurses in the clinic and the inpatient. We managed to make a business case to increase our consultant body in the diabetes endocrinology by 1 consultant, and we set up some weekly MDT education sessions with both diabetes nurses and separately with the endocrine team, as collaborative working with our colleagues in the pediatrics and the biochemistry unit, and also starting to work wider with the regional team with Leicester and Cambridge. So this increased our knowledge and our academic rigor, and we had more availability to highly skilled or highly knowledgeable colleagues in the academic centers to discuss our cases. And we started to reshape some of our activities to improve the service. So my job plan from August 2020, so 2 months after I started as a clinical lead, to a few months ago, or at the moment, is 13.5 PA of activity. This is that my GIM, so general internal medicine activity, didn't necessarily change. What we changed that at the beginning, we were 3 consultants with a 37-bedded ward. So we used to divide patients 2 of each, and we would go and do ward run every single week when we were around, which is almost 40 weeks per year. COVID came and we changed it, and we had 1 extra consultant, and we changed our working pattern, and we started doing 6 weeks on the ward, 8 weeks off the ward. The patients that I see, all of you have seen what happens in the inpatient or general medicine. I don't necessarily have diabetes endocrine patients in my ward. However, we try to attract, for example, diabetic foot patients or DKA patients, or the electrolyte imbalances to our ward. So it's a bit more diabetes endocrinology if we can manage it. But being on the ward and off the ward would give us the opportunity to focus on the inpatient and then switch off and do the specialty activity, which is what we have been trained for as a diabetes endocrinology specialist. And then with the changes, rather than having a general diabetes clinic, we started to be able to cohort our activity. For example, general diabetes clinic, I enjoy classification on young adult type 2 diabetes and type 1 patients, so started to shift my clinic, general clinic, to these 3 cohorts. We set up a technology and pump MDT service as of last year. We have set up a monogenic diabetes clinic linking with the national service, and we have joined the national cohort and the regional meetings on a regular basis. We have set up as I started as the first intervention, a pre-existing clinic, and now we have preconception clinic and postpartum diabetes clinic. We have the joint case reviews with our nurses and dietitians. We do inpatient reach on a formal basis, and we have provided availability for GPs for referral, and we are active in commercial research with the diabetes ward. In the endocrine side, we also started to change things. So general endocrine still continues because we need that. But from there, the general endocrine patients, I can divert them. I have a transition endocrine clinic now with a pediatric colleague. We have set up a proper thyroid clinic, which I supervise the pharmacist who runs that. We have an adrenal instantanoma clinic. We have a pregnancy antenatal clinic. We have joint case MDTs for adrenal and complex, both locally. We do the monthly adrenal MDT and the complex cases, as well as joining Leicester and Cambridge for a regional meeting. We have patient education clinics. My PhD and my research interest was on group education for patients with PCOS, but we developed that, we expanded that. and we started to have a regular group education session for PCOS, for people with adrenal insufficiency. So we teach them sick day rules and the emergency kit, how to use the emergency kit. And because dominantly of our hyperthyroid patients are Graves patients, we have set up a hyperthyroid group education session which go through the principles of the treatment and what their disease is. So patients get diagnosed, come to the group sessions. We still for also with the endocrinology, we have the inpatient Enrich as a consultant, as also availability for GPs for referral. And we also have participated with national teams or Imperial College, for example, for some research activity. So this is in the past 48 months, is individual patients, does not include follow-ups. So if just one single visit of the patients in my clinics, I've had just over 2,000 patients, and it is almost 60% endocrine, 40% diabetes. In that, this is a typical DGH case distribution in my clinic. And this did not include the DNAs and the gestational pregnancy clinics. The case mix in my diabetes cohort are type 1, type 2, and because we do academic formal classification, almost 15% of our patients stay unclassified until we get to the time that we can properly do a C-peptide on them and classify them. In my endocrine, I have data specifically from my SPR time, the gray bar, to my first 9 months as the consultant, the blue bar, and the red bar shows the whole past 48 months. And you can see that we started to divert some of the thyroid patients out to the pharmacist, our pharmacist clinic. So we made availability for other cases, and then we started to see a better distribution in our clinic. What happens in my time as a consultant is the planned activity as a job plan, which are those set activities of the ward round or the clinics, as well as we have a lot of admin time and chasing results, calling patients. Patients call, we need to return their call. The advance and guidance and referrals from GPs. GPs either directly write to you or put it on the system, and we have a rota for that. And meeting families, meeting patients, going to the ward, dealing with the unwell patients as an unplanned activity. So all of these things tend to fill up the whole time from when we come to the work at, I don't know, 8, and then when we leave again, sometimes very late, but all enjoyable. But as a summary, I think we are all master of our own destiny. So looking at my own activity, I managed to change over the 4 years, which is not a long time within the context of the consultant job. A general 1.5 PA diabetes activity was changed to pump research, inpatient, monogenic pregnancy, and complex cases. Similarly, for endocrinology, I managed to set up transition, do some research, pregnancy clinics, complex cases, education clinics, thyroid clinics, and inpatient Enrich, which again it increased the diversity of activities that I had and then made it more enjoyable to work as a consultant. And that's my presentation for now.
Thank you very much, Hamid. That was a really fascinating insight into diabetes and endocrinology in a DGH. Again, we'll take questions at the end. So there are some questions coming through on the Q&A, but just as a reminder, if you can pop them in the chat, and we'll come back to Hamid with the full panel at the end of the last talk. Thank you very much. So we'll move on to the final talk then, which is Dr. Anis Mukherjee, who is a consultant endocrinologist in Manchester, as well as an author. She has a clinical interest in reproductive endocrinology, menopause, thyroid disease, pituitary disease, calcium, bone disorders, and late effects of cancer treatment. Dr. Mukherjee is also an active member of the Society for Endocrinology, having served on both clinical and program committees, and also contributes to the Society's reproductive endocrine network, the magazine, The Endocrinologist, and also the patient website, You and Your Hormones. She's also a member of the British Thyroid Association and British Menopause Society, and recently co-opted to the BMS Medical Advisory Council. And Dr. Mukherjee also found time to publish the Complete Guide to the Menopause, which was published last year. And Dr. Mukherjee will be giving her insights also into career in endocrinology and following your interests. So over to you, Dr. Mukherjee.
Thank you very much. So yeah, thanks very much to the organisers for asking me to share my career journey and to explain to you all why endocrinology is it. So I'm going to give you the big picture here. So during the next few minutes, I'm going to talk about why I chose endocrinology, how I shaped my career, why I think you should at least consider endocrinology. I'll give you some top tips if you're on the fence about your career choices, and how to find your niche. So why I chose endocrinology? Well, you may call me biased, but it's the most interesting and diverse specialty. And I know that you might think I'm biased, but I will elaborate on why I believe that and give you some evidence later in the talk. I loved GIM as a junior doctor, and I think GIM skills are hugely important for infrastructure in any career. So that was always good because it's really useful in endocrinology. I love the fact that endocrinology is a mixture of acute and chronic conditions that span across the adult lifespan. And I also particularly loved that I would be involved in all the hormone transitions. So puberty, pregnancy, fertility, and menopause, we're often asked to get involved in issues around those. I love the fact that endocrinology is a mix of rare and common diseases and a mix of mostly benign, but also some malignant pathology. So it's incredibly diverse. And there's absolutely bucket loads of cross-specialty working in MDTs, with all the different common and rare endocrine disorders, and with all the incidentalomas that we're finding through other specialties doing, more imaging in this imaging revolution era. So, I mean, with all of that, endocrinology is incredibly pluripotential. And I would want to emphasize that it is a very friendly specialty, and I'm not just being biased. I know what other colleagues in different specialties talk about their specialties, and not all specialties are like that, but it's a very, very friendly specialty. This is a picture of myself with a lot of my colleagues at one of our lunchtime meetings that we used to hold regularly in the NHS. So that's why I chose it. So here's my career journey. I started off very long time ago, I'm long in the tooth, going to medical school in 1992, University of Manchester. I stayed in Manchester for my core training as an SHO, as I was in those days. And I got my MRCP in 1995. And actually, after I got my MRCP, my next job still on the SHO rotation was in endocrinology. And I absolutely loved it. And I was sure that that's what I wanted to do. I kind of knew before, but that sealed it for me. So I then went off to seek a specialty training post, and I got a specialty training post in South East Thames, on the South East Thames rotation the following year, starting at King's in diabetes and endocrinology. And once again, I did loads of GIM, which I absolutely loved. And I was lucky enough to get funded for an MSc in diabetes and endocrinology through King's College London part-time as part of my full-time training. So that was absolutely brilliant. And I know those sorts of things aren't widely available, but it was a brilliant opportunity. I then completed, I went through the rest of my clinical training, but towards the end of my clinical training, I had been delaying taking up a research post because my other half, who's a chest physician, was also looking for consultant jobs. And I ended up, he was coming to Manchester, and I was really excited to work, to do some clinical research. And I got a research fellowship at Christie Hospital with Steve Shallett, who was a very eminent professor in endocrinology. And so I did my research fellowship at Christie. And the University of Manchester between 2000 and 2005. So I was there for 5 years, and that was because I had 2 lots of maternity leave. That's my kids. That's not how they looked when they were born. Obviously, that was a little bit later. So I had some maternity leave, but did lots and lots of research and clinical. Got lots of clinical experience during that time as well. Did my MD, which was all on novel aspects of hypopituitarism in adults. And then I went back into clinical training to complete my clinical training part-time as an SPR at Salford Royal NHS Foundation Trust in 2005. And I then was lucky enough to then get a consultant post at Salford as I was finishing my training in part-time in 2007. So since 2007, and I think it's important to emphasize this, my career has evolved and metamorphosized a lot. And I'm probably not, you know, the usual endocrinologist, and you'll learn about that in the next couple of slides. But that's okay, because we are all different. And I think it's really important to be aware that your career can metamorphosize and change. You know, and that's good. You know, you're not stuck with the same thing. If you want to be doing what you were doing at the start of your consultant career right the way through to the end, that's fine. And if you don't, there's lots of opportunity for change. So I was very, very interested in postgraduate medical education, and I got very involved in that in Manchester, working as a senior lecturer with the University of Manchester and leading training in diabetes and endocrinology at Salford. I continued my clinical work, expanding the pituitary services. I led the thyroid service, had a menopause interest, and got very interested and did a clinic in endocrine-related fatigue. And during my early years as a consultant, I really recognised some unmet needs. You know, how we deliver healthcare is changing. We've certainly learned that from COVID, but there are lots of areas with unmet need. And I expanded into endocrine-related performance issues in elite athletes with overtraining syndromes. I got very interested in chronic fatigue and also menopause and women's health. And some of that work, because, you know, elite athletes tend to be in the independent sector, some of that work I did started to develop in the independent sector, and I started to do some direct to public work when I realized that a lot of people, and particularly women, are going to the media and social media for health information. Over the last decade or so, I've also worked on the program and clinical committees for the Society for Endocrinology, you know, looking at the big picture on how we're delivering services and training. And I've worked on the Medical Advisory Council for the British Menopause Society as well. So in recent years, I've got very interested in direct to public healthcare delivery, because I've seen firsthand on social media and in the media that there's a lot of misinformation. And I've built up a sort of a following on social media. I've got 40,000 followers on Instagram. That I think I'm called a micro influencer with that amount. But, you know, I think I make a difference there, balancing the conversations away from a lot of the monetizing menopause, monetizing women's health, and other endocrine related problems like, you know, thyroid disease, where people are often sold products that are not real, not the real deal. So I was actually approached by Penguin Random House a few years back in 2019, just before the pandemic, to write a book about the menopause. So I thought, yeah, okay, that's going to help some women. And that was published slightly later because of the pandemic in 2021. And I continue to work closely with the Society for Endocrinology, British Menopause Society, and several charities. I'll just click on all my pictures there. Delivering factual information to the public, trying to get rid of misinformation in relation to endocrine issues and women's health. And we recently produced a position statement. I lobbied the BMS and the Society. I think they probably got sick of hearing me talking about all these problems, but we then subsequently worked together along with the Royal College of Obs and Gynae to produce a position statement, which was published in Clinical Endocrinology in June and also in Post-Reproductive Health, really to try and address the misinformation about menopause in the media. And of course, the media is relevant. And so far in 2022, I've kind of done quite a lot more media work. And I'm not saying that you need to do this. I'll talk about your career and what you should be thinking about in a minute, but this is just me. This year, I featured in, you might have heard of Davina McCall, who's very much in the media menopause space. I was interviewed by Davina on her couch for her menopause documentary, featured in that. I was interviewed did a feature interview on the Real Housewives of Cheshire menopause documentary. My book was featured in a POI storyline on Coronation Street, the soap, in August, I think it was, on this year. And I featured in lots of news articles and podcasts aimed at empowering women. It was very fun, and I was honoured to be featured on BBC Breakfast a few months back this year, and I was interviewed, or rather grilled, by Naga Munchetty, you can see in this picture here, and Charlie State, about an emerging menopause news story. I've also been working with the British Menopause Society on a menopause teaching tool for clinicians to try and improve delivery of menopause care, in the grassroots. And I'm doing some research into menopause and lifestyle interventions. So that's me. And you might be thinking, wow, that's a bit different from the previous talks. That's a bit out there. But, I think the message is that there's lots of different opportunities. I mean, really, the world is your oyster with endocrinology. Okay, so why should you consider endocrinology? So what I would say is endocrinology is an investigative specialty, almost like being in the intelligence services. And my previous colleagues who've given talks have been very understated about it. So I'm going to be right out there and spell it out. You've got to have brilliant clinical acumen, from picking up Cushing's in your clinics, bitemporal hemianopias, Addison's, BOs, insulinomas, along with endocrine-related fatigue. You've got to be at the top of your game and on the ball. These are all conditions that are often, missed for years in patients and end up presenting very late. And you might think endocrine-related fatigue sounds quite dry. Well, this lady came to my fatigue clinic with more than 6 months of fatigue for advice about managing her fatigue. And I took a history, and it's the clinical acumen and the GIM experience that gives you can spot the red flags. And this lady, I sent her straight for some imaging. She had a glioblastoma multiforme. So I know that sounds like one isolated event. It's not. I see red flags all the time. I could give you a whole talk on, the pickups that I've done in the endocrine and chronic fatigue clinics. When it comes to endocrine biochemistry, there are also infinite possibilities, from interpreting thyroid function tests, which you might think, well, they should be straightforward. Oh, no, there's all sorts going on behind the thyroid function tests, to baseline pituitary function tests, to inferior petrosal sinus sampling interpretation, to adrenal vein sampling. These tests are very detailed, and they require a really in-depth understanding to interpret. And when I talk to GPs and when I talk to trainees who I'm teaching about these, I describe us as endocrinologists like a fine art expert looking at a painting. When I go to the Louvre or a wonderful art gallery and I look at amazing paintings, I think that's a really great picture, or maybe that's not such a good picture. And I think when GPs and medical students and others will look at endocrine testing, they'll think, oh, that looks normal, or that doesn't look normal. As endocrinologists, we read so much more into those results, and it's a pleasure. It's an art in a science. So, that is in itself a very, very interesting aspect of the job. And then there's imaging, talked about the imaging revolution, all the MDTs, where we're picking up incidental adrenal nodules, thyroid nodules, pituitary lesions, etc., pancreatic lesions. So imaging from the good old thyroid ultrasound scan to dynamic pituitary imaging to octreotide scans and metomidate PET CTs for adrenals. There's all sorts going on with imaging, and it's really interesting doing the MDTs and looking at the imaging with the radiologists in site and doing clinical correlation and also biochemical correlation, of course. So, it's just so fascinating. Okay, so furthermore, why choose endocrinology? And I'm just going to give you a few little snippets of cases. So Derek was a patient I saw a few years ago. He's given me permission. I was given permission to show these pictures. So if you look at Derek and you think, she's an endocrinologist and she's giving us a slide, what could this be? And I can't get you all to shout out what you think he's got because we're online and you're all muted. So, please do write down in the chat box what you think he's got. But I mean, I'll give you a hand. He's pigmented. He's got poor wound healing. He's got easy bruising. He's a bit plethoric, isn't he? He's got moon face. What are you thinking? What's this in his neck there? What are you thinking? You're thinking, I know what you're thinking. You're thinking, he's got ACTH-dependent Cushing's because he's pigmented, his features suggest Cushing's. And, you know, lo and behold, he's got a little pituitary lesion on his pituitary MRI scan. So you're thinking he's got Cushing's. Well, Derek was seen for several years in various services, having been diagnosed with Cushing's, and he came to my service, you know, as a patient not responding to treatment for refractory Cushing's. So Derek was 61, and he actually had Cushing's syndrome secondary to ectopic ACTH from a metastatic neuroendocrine tumor, and it was a medullary thyroid cancer. This was an incidental pituitary lesion. This was his octreotide scan. And he had CEA and calcitonin that were absolutely off the scale. So, you know, if you think Cushing's is straightforward, you speak to any endocrinologist with enough experience and they'll all say Cushing's is incredibly difficult. It's difficult to diagnose, it's difficult to investigate, and it's also difficult to treat. So there you go. Then on the other side of the coin, how about menopause? I've talked about this to you already. There's a menopause revolution out there in the media and on social media, and all the celebrities, the midlife celebrities are talking about it. We've got government bills on this. We've got, you know, HRT shortages. I'm sure you've heard about that in the news. Everything, every symptom in midlife women is being put down to menopause. So I saw a lady in my clinic recently, and I see lots of patients with menopause, and she'd been seen by a GP with a specialist interest in menopause. She'd done a diploma, a couple of days, diploma in menopause, and she had been giving this patient more and more estrogen for refractory genitourinary symptoms of menopause. She had a lot of pain and discomfort down below, and she'd been given all sorts of vaginal treatments, systemic estrogen in big doses, and wasn't responding. And she'd come to me as a second opinion. And I wasn't happy with these symptoms. I asked her about the symptoms, and she was talking about some sort of dysthetic sensations. And I asked her some questions, really simple. And she told me that she'd lost temperature sensation, and I wasn't happy. And she had some back pain, so I sent her for a scan. And this was her imaging. I hope you can see it. I hope these images aren't in front of it. She had a spinal tumor. It was all being put down to menopause. So you've got, in endocrinology, you have to be on the, you know, you have to be on the ball, but there's never a dull moment. It's fascinating and interesting, and the things you pick up are just so diverse. So, you know, and the moral of that story is don't put everything in a midlife woman down to menopause. So, you know, that's the clinical side, and I am very much a clinician, but I can't do this talk without talking about endocrine science, because endocrine science is in the dawn of a new era. I mean, it's always been interesting, but my goodness, when I go to the endocrine conferences and hear about what's going on at the moment, it just sort of blows your mind. So, you know, we've got kisspeptin, all this going on with fertility and puberty, amazing research. We've got, you know, the research that's going on endocrine disrupting chemicals, which are, you know, threatening fertility of future generations, and that's a really important area of research. We've got a new era in obesity management with some unbelievable scientific developments in multi-level, multi-channel products incorporating several molecules to treat obesity. I've taken that from a wonderful talk article given by my esteemed colleague, Professor Akhil Saeed, who's an obesity expert in Manchester and who I shared an office with for many years. And this is a super article in the Endocrinologist from the summer of this year. And then, of course, having an interest in menopause, I have to mention the neurokinin 3 receptor antagonists pioneered by our very own Imperial College London in the UK, but now being researched across the world, and are probably going to be a first in class practice changing management for menopause symptoms, which treat menopause symptoms without the need for estrogen. And, you know, there's NK1 and NK2 receptor antagonists, which are being developed for other things. And, you know, that is a tiny little snapshot of some of the amazing endocrine science that's going on. So, you know, if you're interested in research and science, it's all happening in endocrinology. So I'm just going to give you some top tips if you're sitting on the fence. So think about the changing models of healthcare delivery and science as well, and how they may impact on your career choices going forward. Can you predict what's going to happen and what you might like to specialise in? Remember that endocrine skills are really growing demand, because common endocrine conditions such as obesity and menopause are not going away anytime soon, and there's going to be an increasing need for those skills. If you're considering academic science, I hope I've convinced you that endocrinology is absolutely full of opportunities. But equally, if you want to spend your life in a cath lab or an emergency department or an operating theatre, then endocrinology may well not be for you, because it's not heavily procedure based. So how to find your niche? If you don't already know what you want to do, that's okay, don't worry. Virtually no one has it all figured out, and that's why it's okay for your career to metamorphosize even after you've become a consultant. It's also true to say that life outside of medicine can shape your career choices, and that's okay too. Endocrinology is actually a specialty generally with great work-life balance opportunities. I would say, I was blessed to do a lot of clinical research, and if you get any opportunity to do a clinical fellowship, even for a few months, or a research fellowship, I think these can be really invaluable to help guide your direction, help you understand what you enjoy or what you don't want to do. In your career, whatever you're doing, always try to see opportunities and not barriers. And I would say this is really important. If you choose what you enjoy, the rest should actually follow naturally. So that's Hormones, the Inside Story, Whistle Stop Tour. And I'm very happy to answer questions during the panel discussion.
Thank you very much, Dr. Mukherjee, for an insight into how varied endocrinology can be. I think you've convinced everybody. If Hamid and Jolyon want to put their videos on, and we can get started with the Q&A. Just to remind everybody who hasn't yet submitted their questions, you can carry on doing that during the chat. But there have been plenty so far to keep our panel busy, so I will get started with a few of them, but please feel free to keep popping them in the chat. So I'm just going to start from the top really and start working through. One of the first questions was about what to do if you're working in a hospital where there isn't an endocrinology department. Does anyone on the panel have any advice for sort of getting involved in projects to show some interest and starting to participate in that if you're in such an area? I don't know, Hamid, if you're in a district general, it might be that sort of environment, given there's probably smaller departments. I don't know if you want to kick us off.
So if you're not working in an endocrine department, if your attachment is not with an endocrine department, you can always approach the consultants. And there's generally always a project, something to do in the department. We always have a question to answer. We always have some data to analyze. We always have a cohort of patients to follow. So, and almost all of the consultants are approachable. So make an approach, send an email, and in a DGH generally, almost all of the consultants do some sort of the internal medicine, either on-call or have a ward basis. So you can approach them either through the on-call, can encounter them in the on-call, or literally walk into the department or send an email. In catering, you're more than welcome to email us, and I think that applies to almost all of the consultants across the country, wherever they work. There is always something to do.
I think that's probably very true. I don't know if Dr. Mukherjee or Jolyon, if you had anything to add to that, but I think that's probably some very good advice.
Yeah, I think there's so much endocrinology in GIM that if you're working in a department with GIM, there are always projects that you can look at that, link in. You've got diabetes patients coming in through A&E, rates of hypoglycemia. There's little audits that you could do as GIM audits that link in with specialty.
Yeah, just to give two examples, I remember based on we had a good hypoglycemia audit done by a cardiology SHO who never did any attachment with us. And we changed over EPMA, electronic prescription, done by another GIM SPR who never did endocrinology, but they looked into levothyroxine prescription and they did a quality improvement project, and they changed the EPMA prescription approach to levothyroxine. So always something to do, always.
Plenty of opportunities. So there was a very specific question about the role of pharmacists in thyroid clinic, but Anis, you touched on the role of sort of the wider MDT and the variety of MDT members that we can work with as endocrinologists. I don't know necessarily you want to answer the question about pharmacists in the thyroid clinic, but perhaps touch on sort of the wider MDT and the interactions we have.
Well, I mean, I didn't have we had a pharmacist involved in ward endocrinology, but, you know, in our MDT, we have never had a pharmacist, but I think Hamid does. So I think he's the one to answer that question.
So endocrine, in the endocrine working group, they have a role for endocrine nurse, which is traditionally recognized. There is a curriculum for training of endocrine nurses, which was developed one of the senior endocrine nurses in Leicester. In Kettering, when I started, we had a ward pharmacist. She was very interested in endocrinology, and I thought, why not? So if a nurse can have a role, why not a pharmacist? And so we worked on that. We developed a business case for endocrine practitioner rather than just a nurse or pharmacist. She applied. We sent her to different units, to Birmingham, Oxford, Leicester. So she saw how the endocrine nurses work in those big units. She did a couple of courses, and then we set up our thyroid, which we already had a thyroid virtual clinic to follow up our Graves and hyperthyroid patients. So we set up a clinic, and we gradually sat with her, and now she's running our thyroid pathway. And similarly, our adrenal incidentoloma cases, she follows the international guidelines and follows the pathway to investigate them. So now the endocrine pharmacist for us, she's running 2 of our big cohorts, and she leads on our MDT. And now she's expanding. We are planning to give our primary hyperpara patients to her. So there is a role for them. And now she has written an article in the endocrine journal, in the society's journal, about explaining her role. So hopefully we'll see more of the pharmacists in the society as well.
Yeah, no, absolutely. Moving on, Jodie, and this is probably towards you, but I imagine all the panel may have an opinion. If they choose an academic pathway, after the 3 years of that, would they then join back into the clinical ST4 to 7? I know this has changed a little bit with internal medicine training now, but I don't know if you touch on that.
So my understanding is that the academic pathway is still run through, but your length of training will increase, obviously, in terms of doing the academic year during IMT, and obviously any time for doing an MD or PhD during that time. But my understanding is it's still run through, but I know there's already some differences between areas.
Yeah, and I think talking to local training program directors is probably a good starting point, because there is a lot of changes going on with that at the moment. One question specific to sort of the foundation doctors, if as a foundation year 1 doctor, if they're interested in diabetes and endocrine, is there anything they can do in particular at the moment to further their interest? So they've mentioned taster weeks. I don't know if anyone wants to take that question in particular.
Yeah, so you're entitled to 5 taster days in F1, F2, and this gives you a chance to go to see specialties that you may not see during your training programs. So I think I would encourage people who are interested in diabetes endocrine to, at the start of the rotation early on, because there's obviously time pressures on the wards, say I want to do taster days on such and such a days, and then get in contact with your local diabetes endocrine department. I'm sure they'd be happy to have you in. This would give you a chance, particularly to the outpatient stuff that you won't necessarily see as an F1 on a ward.
Yeah, that's some very good advice.
And I can add that I suggest that you, even if you wanted to go to another unit, you probably can go to a better unit. So I was the first cohort of F5-1s in the country. 2005 foundation year program was introduced. At that time, I was a bit interested in stroke medicine. So I made a case, and the BMA supported that application, that I went for 5 days to Edinburgh to see the stroke unit as a kind of a taster week. So this is something which is recognized, and you can go, say, for example, to Manchester and see an academic unit of endocrinology if you wanted to see how things work, or to Oxford, to Cambridge. So it's in your right, you can ask for it, you can make a case for that.
So plenty of opportunities, I think, is the message there, just asking for them. This is probably quite a good question. I don't know if each panel member wants to give one answer. What are the essential skills required to be an endocrinologist? So you've all touched on elements, but if you're going to give one answer, we can start with you, Hamid, if that's okay.
Be interested, be curious, and don't give up, because that's as Anis was saying, that it's a brain challenge, is that you want to answer a puzzle. So carry on and being interested and inquisitive.
Anis, yours?
Well, I think that GIM is crucial for endocrinology, because you just have to know about every other system in order to fit it all together. So, you know, I think if you hate GIM and you just want to only do, I mean, I suppose you could do endocrine science and specialize in one particular bit, but I think as a clinical endocrinologist, GIM is crucial as part of your armamentarium to be able to, you know, fit it all together and solve the puzzle or the intelligence, you know, quiz.
Julian, did you have any?
Yeah, I would say two things. I'd say enthusiasm, love the specialty, and over my registrar years, my enthusiasm has grown, and I'm sure that's the case for many people going on as consultants. And secondly, intrigue. I think not taking things as face value, always thinking, have I got the whole picture here? And particularly some of the cases that Anis mentioned, I think you need to have that intrigue and just sort of not saying this is definitely the case.
Yes, so some very important skills there. This is a very specific question, and hopefully someone can answer the question. From an IMT1, whether sports endocrinology is an option after CCT. I don't know the answer to that. I don't know if anyone does.
So I don't know the answer, but I do know that there are groups across the country who deal with the sport and athletes and elite sports. So, for example, Rob Andrews' group, they work a lot on both on endocrine and diabetes side. So Oxford group, I know that they work in the pump technology with exercise. So definitely there is room to explore. Then there are ways to go and do fellowships with these groups who specialize in that. Again, in the field of diabetes, once a year we have an XTOD meeting, which is exercise in type 1 diabetes. So definitely there is excess room for exercise, and there is lots of research happening in that. John Moore's University in Liverpool, they focus on hormone changes in exercise and athlete. They work, say, for example, Novo Nordisk. They have a bicycle, they have a cycling group, and they do lots of research and publications on that. So there's lots and lots to do in diabetes and endocrine side on the sport.
And I just say, I mean, I do a lot of that work, but I kind of did it as a consultant. I didn't get any specific training. It was just the training that I did as a consultant independently. And I worked in the independent sector at an institution called the Manchester Institute of Health and Performance that it has pretty good financing for sort of research as well. So that's quite a nice place to look at, to possibly go and do an attachment, because it's got state-of-the-art facilities for sort of endocrine sort of performance in elite sport. But I think, yeah, Rob Andrews Centre in Bristol, I think he is excellent. And there are other centres specialising in the diabetes side.
I think he has moved to Exeter now, Rob Andrews.
Does he move to Exeter, right? Yeah.
Okay, so again, plenty of opportunities, not sure if it's a specific specialty, but plenty of opportunities around the country by the sound of it. Hamid, this one might be particularly for you, from a IMG doctor asking about pursuing a post in diabetes and endocrine in the UK, and whether there's opportunities to do clinical fellowships without the specialty training in the UK.
So we do get clinical attachments, and to get hands-on, as far as I understand, you need to pass the PLAB, be able to practice in UK. But as clinical attachments, we do get a lot of IMGs. They come and spend months for us. And if you enter and you're allowed to practice in UK, you cannot come and work with us. We have had trainees, we have had people who came and did a year with us as a trust grade doctors. They were already trained as internists, so they came and worked with us. And one of them is now successfully doing year 3 of national training in diabetes endocrinology in North Rotation. So it's the possibility to come and work and do some training and then apply for the national training. And also, if you wanted to carry on in a local area, if they're able to support, There is a CISO route to go through the training, and that's outside the national training, and you can get the competencies signed off and become a specialist in the field.
Okay. And do you have any tips for sort of where to start? Is there particular forums or contacts that you could suggest?
So you can contact the localities that are generally, so at the moment, I can't say problem, but as maybe an opportunity for some people, there are lots of gaps in almost every NHS hospital. So, and they are looking for international graduates as well who are able to work. So that will be a starting point where you can come to work, and then in that local hospital, you can start exploring, linking with that specialty that you want to do, start working with them, doing some projects with them, attaching yourself, and then take it after that. So any local area that you want to work in, Kettering General Hospital possibly accepts that. I think almost every NHS hospital will accept that because there are gaps in the road almost always.
Yeah, absolutely. I'd just add to that from a YDEF perspective, we do have a specific IMG rep on the committee, and their contact details are on our website. So if you're really struggling to get responses or know where to start, we have a specific person who has a lot of information about that. So if that might help as well, if that's just a suggestion.
And I personally don't mind being emailed, and you can share my email about that as well.
Fantastic, that's very kind. That probably just brings us on to the last question then, just in the interest of time. Someone's asked about any additional sort of courses, conferences that any of the panel could suggest to get, added value when preparing for higher specialty interviews or applications. Jolyon, if you wanted to kick off.
I think the best endocrine conference is the Society for Endocrinology, the British Endocrine Society conference every year in November. It's in Harrogate in about 4 weeks' time. As a undifferentiated clinical trainee, the rates to attend are quite low, and you can also get grants to attend. I think I would always encourage you to submit a poster, poster abstract, which the deadline is normally around June time. So I think that I would say is the best one, but that's not the only one. Diabetes UK do several conferences on the YDF website. Obviously, I'm sure you'll say, Becky, there's a calendar of diabetes endocrine conferences. So I think, and obviously, if you can't physically travel to some of the webinars that the Society for Endocrinology do, so that would be, so there's lots you can do. But I'd start with the websites that I put up earlier, because they'll always advertise their conferences.
And I think
the SFEBS is brilliant, and they've also got, the society also has the National Clinical Cases meeting, and they encourage junior trainees to submit cases, and that's been online the last couple of years. I'm not sure if it's still going to be online, but that's also a really good, one to start with if you want to get a taster of endocrinology and diabetes.
Hamid, any additional ones from you?
Just to add on that, I think those are very comprehensive. Diabetes UK Society and the events of those websites. Royal Society of Medicine also every now and again does some kind of meetings on endocrinology. So if you put yourself on the feed for the Royal Society, there are some good talks there as well.
Fantastic. So I think we can probably wrap up the questions now. There were a few questions throughout asking about other webinars and things. The Society for Endocrinology will send out a post-webinar email to everybody who's attended that has a survey on for you to complete. And if you do the survey, you can get a certificate if you would like. And that will have lots of other information which has been touched upon during the various talks and the Q&A session with regards to other courses, and also the Society for Endocrinology webinar series, which is a really good starting point and has been mentioned a couple of times. And I believe there's sort of a free taster of one of those. And then I think if any of the speakers are happy to be contacted, that information will be passed on to you all as well. So I don't know if there's anything else from the panel to add to close, and if not, we can finish there and wish you all a very pleasant evening.
Thank you so much.
Cool, thank you.
Thank you.
Bye.
Bye.